back on the Zero Hour. As always, I'm your host, Richard RJ Eskow. We talk a lot about Medicare on this program for good reason. Medicare has been around since the mid-1960s, along with Social Security. It is perhaps the most successful and most popular government program we have, with emphasis on the word government. It is a program that, while the private sector has made inroads recently in the last decades through both the Medicare Advantage programs and private sector drug plans. Basically, traditional Medicare is something that people have known. People know they can rely on it, has many millions of members. But there is a tendency underway, or perhaps tendency isn't the right word, perhaps creeping infestation is the right word, of traditional Medicare by the private sector. It's happening under the radar. A lot of people don't know about it, but it's very important that we do understand what's going on here and its potential implications. So here to join me now to discuss that is our good friend Diane Archer. Diane is the president of Just Care USA. She is a policy expert in healthcare as well as Medicare. And without any further ado, Diane Archer, welcome back to the program.
Thank you for having me, Richard.
So these new intermediaries, whatever you want to call them, that are being slipped into Medicare, I would argue without enough public debate or discussion, it's called direct contracting. But that strikes me as something of a euphemism for putting insurance companies and their investor backers in charge of deciding who gets medical care and who doesn't. Is that unfair of me to see it that way?
I think that is, you've nailed it. It's exactly right. What we're seeing is, thanks to the Trump administration's initiative, an influx of insurers and investors into the public side of Medicare, the side of Medicare that people choose because they don't want an insurer between them and their doctor, second guessing their doctor about the care that they need. So we already have Medicare Advantage, as you mentioned, and the Medicare Advantage plan has been shown to be a lot more costly than traditional Medicare. And a lot of people continue to choose the traditional Medicare government-run program because the government gives people the freedom to work with their doctor to decide the care they want from the doctors they want, at the hospitals they want, anywhere in the country, and to get coverage for that care.
And, you know, Diane, it's just personal for me in a lot of ways, including just quick digression. Someone very close to me who is on Medicare has cancer. And the best treatment available for this particular form of serious cancer is at Memorial Sloan Kettering. And there's one proton something machine up in East Harlem. He would not be able to, under Medicare Advantage or, for all I know, under direct contracting, be able to go, we did a lot of research to get to this point. He would not have that option. His life and death statistics, his likelihood of surviving this would be different if he were in a program like Medicare Advantage that can decide, well, that provider, we don't contract with that hospital or whatever. So what I'm concerned about here is, first of all, a lot of people enroll in Medicare Advantage not realizing that that could happen when they get sick. But secondly, now with this thing called direct contracting, I'm afraid that even people who choose traditional Medicare because they don't want that may suddenly wake up one day and find that they can't see the doctor or go to the hospital they want. Are my fears unfounded?
Well, that's a really good question. Let's just step back for a second and look again at Medicare Advantage, where, as you say, it's pretty hard to find a Medicare Advantage plan that contracts with centers of excellence, with the Sloan Ketterings and MD Andersons and Mayo Clinics, and allows their members to get coverage for care from these first-class, high-value healthcare providers. And so a lot of the people who sign up for Medicare Advantage are people who are healthy and don't see the need to go to those plans. or to see those hospitals and go to specialists, and they think they can save money in Medicare Advantage. But in traditional Medicare, you do have the freedom to go to Sloan Kettering and to get the expert care that you want and need if you end up with a serious condition, as you say. So now what happens if you end up in a quote unquote direct contracting entity, really a euphemism for a Medicare Advantage like plan on the traditional Medicare side? Well, the good news is that in theory, you can go out of your entity's network to Sloan Kettering or to whatever provider you want and get the care you want because you are still in traditional Medicare. The issue, though, is that, as you also said, these insurers and investors on the traditional Medicare side are getting paid a flat fee from Medicare, just like the Medicare Advantage plans, to manage your care, regardless of the number of services or the cost of services that you get. Meaning that if they get $1,000 a month to manage your care, which is about what they get, and you need $1,500 worth of services, they lose money.
Right.
If you get $100 worth of services, then they're going to make $900 on you that month. So for them, the game is to minimize the cost of the services you receive, to limit the number of services and to reduce the cost as much as possible. So these direct contracting entities, which can be a Humana, and it can also be an Oak Street or Iora, these are private equity firms, they contract with primary care doctors. If your doctor is a primary care doctor they contract with, then you are involuntarily, automatically assigned into that insurer or investor's direct contracting entity, even though you've chosen traditional Medicare.
So I want to stop you right there, Diane Archer, because this is so important, and I really want people to understand this step by step by step. So, and I'll remind the audience, but I'll remind the audience, I worked in health insurance for many years. I know financing and underwriting and the economics of it inside and out. So nobody wants to insure anybody in the insurance world unless they can make money on it, right? Medicare Advantage, there are known ways to do that. They're not scrupulous, but they're known. Okay, you can say, I'm going to make sure I market to younger, healthier people than are the average so that I make money on the difference. You could do things. I can make it hard for people to get expensive care with my pre-certification programs, my list of doctors, and so on. That's how they do it in traditional Medicare Advantage. But when you go into regular Medicare, as I understand these direct contracting deals, it might be everybody in Birmingham, Alabama, or Utica, New York, or Montgomery County, Maryland. You get the whole Medicare population. So there's got to be a way for them to make money. And the only way insurance companies make money is by denying care. So, and I'm sorry to go on so long when you're my guest, but I just want to set the stage. So I think what you're saying is that at least there's reason to suspect that the way they want to make money in all of this is by doing contracts with your doctors to discourage them from giving you care you might need if it's expensive. Am I on the right track with that?
It makes sense to me that the only way that insurers and investors can make money on the traditional Medicare side is the way insurers make money on the Medicare Advantage side, as you said. And that's by taking the money from the government and spending as little of it as possible on your care. So how do they do that? The only way they can do it is by directing the doctor as best they can to not deliver costly services to patients and to limit the services they give patients, to refer them to low-cost doctors and low-cost hospitals when necessary. Now, we don't know for a fact that that's what they are going to do, but we have seen over and over and over again in Medicare Advantage that the Medicare Advantage plans, as you say, don't contract with the high cost hospitals, the Sloan Ketterings, and they do their best to delay and deny care. In fact, the Office of the Inspector General at the Department of Health and Human Services found widespread and persistent inappropriate delays and denials of care in Medicare Advantage. There is no reason not to believe, or every reason to believe, that those same practices are going to be the tools that the insurers and investors use on the traditional Medicare side. The good news for people in traditional Medicare is that they don't have to listen to their doctor, and their doctor says, go to this specialist. They can go to Sloan Kettering, and Medicare will cover their care. But they have to be concerned that if their doctor is now a member of a direct contracting entity, that individual is not likely to practice the same medicine that he or she practiced before that person was a part of the direct contracting entity.
And again, I'm sorry to interrupt, but this is so important. I want to make sure everybody understands. And that is because the doctor in that case, if they're part of this entity, has a financial incentive of some kind that is not aligned with necessarily, and they may not be nefarious about it, but the fact is they have a financial incentive that is not aligned necessarily with giving you the best care possible, right?
I think you just nailed it. So the direct contracting entity is allowed to say to your doctor, I am giving you $850 this month to spend on your patient. And if you only spend $800, you can keep the additional $50. So that doctor all of a sudden has an incentive not to give you the care that he or she otherwise might have wanted to give you, because there's more money in it for the doctor if you get less care.
Right.
And that is totally allowed. And so what is a person to do? All of a sudden, the doctor is sort of now not necessarily putting your interests first, because there are financial interests that doctor has that might also be at play and may be in conflict with your interests. Now, again, as you said, maybe not, but we don't know.
And my doctor, I'm sorry, go ahead.
What we do know is that the direct contracting entity wants that doctor and is doing what it can to direct that doctor to maximize profits for the insurer or the investor, whoever that entity is, by delaying and denying care, as you say.
Right. And no matter how good my doctor is as a human being, I don't want her to have I don't want her to be thinking, when I treat Richard, I'm losing money. That's not the way I want the relationship to work. And the other dimension of these direct contracting entities, Diane, as I understand it, but correct me if I'm wrong, is that people can be in them and not know and not have any choice about whether they'll be in them or not, right? These pilot programs that Trump started, but which the Biden administration is continuing, they could say everybody in Manhattan's in it, or as I said earlier, everybody in, you name Ventura, California, just make up a city. And I don't have the option, unlike with Medicare Advantage, I don't even have the option to say, I don't want to be in one of these things, do I?
Okay, so you're half right. You're not 100% right. The Biden administration did stop the version of this quote unquote experiment that covered an entire area.
Okay.
And so the only way that a direct contracting entity gets assigned enrollees is if their primary care doctors have treated the enrollee in the last 2 years. And so if your doctor is part now of a direct contracting entity in traditional Medicare, you will automatically be assigned. And as you say, Richard, you may not know, because how would you know? Well, there is supposed to be a letter that goes out. I saw a copy of one of those letters from Clover Health to a patient, and it basically said nothing. I think it's the kind of letter that people might look at, have their eyes, glaze over it, and throw it out if they even open the mail, because it basically says, we're going to be working with you to make your life better. You don't have to do anything. It doesn't tell you you have the right to leave. The problem, of course, is you have the right to leave that direct contracting entity if, number one, you're willing to give up your doctor.
Right.
That's the only way you can leave. And that means that you have to be able to find another doctor. So back to your earlier point about, do you have even the ability to find another doctor? I think in certain areas, certain small pockets of the country, one direct contracting entity might own all the primary care providers.
Exactly.
So you can't opt out.
Let's say if it's, Blue Cross of Alabama and Birmingham, it might be 80% of the doctors in town. So,
exactly.
so
then you have no choice. Then you're stuck.
So recapping just a little bit, first of all, I'm glad to be at least half right since I'm a half-wit, so it seems appropriate. Secondly, I'm glad that the Biden administration stopped this wholesale shoveling of people into this program. But thirdly, I think these rules are so arcane. Right. I mean, if you're a primary doctor in the last 2 years did this or that, you were born on a Thursday and your last name begins with A, this is how they get us in a way. I hate to put it that way. And I guess the third point I'll make about the letter is that strikes me as one of the Medicare regulations on the private sector that are just flagrantly disregarded. In the last 3, I had a medication drop from my own Medicare and a life critical medication. And your friends at the Medicare Rights Center informed me I was required to receive a 30-day written notification before they discontinued the medication so that I could ask my doctor for something. Didn't happen. And I doubt it happens very often. This is Aetna. So I would argue that any program that relies on the voluntary compliance of the private sector is going to be honored more in the breach, as they say. What do you think? I
think that's fair. And I think what's also fair is even when it is honored, you get bombarded by so much Medicare garbage, so much marketing nonsense that it's impossible to tell what is legitimate and what is, just spam. And then even when it's legitimate, the language here, we're talking, if you really wanted to get into this in a way that people wouldn't understand it, you'd be talking DCEs, ACOs, CMS, OIG,
right.
HHS, and nobody would understand anything. And that's what happens.
Right.
We have the Centers for Medicare and Medicaid Services, CMS. We have the DCs, direct contracting entities, and the OIG, the Office of this is all gobbledygook. People understandably cannot wrap their heads around it, and nor should they have to. And then we're talking about, as you know, older people, people over 65, people with disabilities, often with physical and mental impairments, with low literacy levels, with all kinds of other stressors on their lives. I mean, it's hard enough when you're to make sense of any of this. But now, as somebody who isn't well to do so, and it's just not fair. And what has made traditional Medicare a national treasure is that you need care and you get it. And there aren't all these hoops. And yes, there's one problem. And that challenge is the cost of supplemental insurance for people who don't qualify for Medicaid or who don't have retiree coverage. And that's a problem because it's easily $2,000, $3,000 a year for a population, more than half of whom have incomes under $30,000 a year. So that is challenging. And that's why people end up.
And I feel that that's tragic too, because I think what you're doing, in effect, not you, but the government is doing, to mollify and placate and shovel money into the private sector, is they're really kind of holding lower income older people, which, as you point out, is a lower income group, hostage forcing them to join Medicare Advantage plans that they're very likely, in my view, not to give them the care, and certainly won't give them the latitude to choose their care that they would have when they need it. And I think it's kind of a tragic trade-off where, okay, a lot of people don't have the $2,000, $3,000 a year for traditional Medicare with wraparound premium, and then they find themselves unable to go to Sloan Kettering or wherever they need to go for their care. And those outcomes can be tragic as well.
Yes, I think that's very fair. And I want to make one other point, which is that with supplemental coverage, it's expensive, but then you can sleep at night knowing you can go to the doctor or hospital without worrying about the cost. In Medicare Advantage, you don't have the choice of supplemental coverage, which means that you might end up spending or needing to spend as much as $7,550 a year out of pocket for in-network care alone, which means that you are forced to make a choice between your dinner, your rent, your heat, and your healthcare, because you don't have that much disposable income. So you're constantly having to make choices that nobody should have to make about whether you get needed healthcare, which is insanity. So I want to go back now to this new quote unquote pilot, which could end up covering more than 30 million people with Medicare if the government, if the Biden administration decides to let it go and expand it, which I think would violate its authority, but that's a whole other subject. But what it can do, even though it can't prevent you from going out of network, is it can offer you an out-of-pocket cap, much like Medicare Advantage. And if it does that, your doctor may say, oh, you don't need your Medigap. You can save $2,500 a year. So long as you're in network, your care will be covered at no greater cost than you would spend with Medigap. And then you can imagine a lot of unsuspecting people will feel like, I can save money, and then they'll need the care at Sloan Kettering. Yes, they can go get it. They'll be liable for 20% of the costs. They will no longer have Medigap, which means that they probably will not be able to go out of network to get the care they need. And that is where, it becomes really scary. We just don't know how this all is going to operate. But what we do know is that the federal government is willing, literally, to hand over to Wall Street, to these insurers and investors, millions of lives of vulnerable Americans to manage their care. And I say manage in quotes because, as we've discussed, what they're really managing is the money that they've received from the government, with the focus on maximizing their profits. And they can actually, under this new experiment, they can make 40 cents on the dollar. So out of a $10,000 payment that they get per person, or whatever it is, 11,000, they literally can pocket 4,000 or more if they don't provide care to people. And there is no way for the government to effectively monitor whether they are appropriately denying care or inappropriately denying care. And there is no way for an individual, either in Medicare Advantage or with DCEs, to know the difference between them. Like which one actually is going to give me the care I need. They're all supposed to be different, right? So they all behave differently. That's even acknowledged. But now asking anybody to choose the right one, how would you possibly know? How could you possibly make an informed choice? There's no good information to tell you.
And I strongly doubt that people will be even aware that there's a choice to be made, right? Because they're just, I see my doctor, she joins this thing. Maybe she tells me, maybe she doesn't, but she changes her practice of care with me. And I don't know what I'm missing. I don't know what I'm not getting. I don't know what options aren't out there. If I don't like it, if I become aware of it and I want to change, then I have to find a new doctor, which is a big hassle. So it seems to me, stepping back from the individual, how this affects the individual, it seems to me, one, that this is just laying more traps for Medicare recipients, number one. But number two, from a government point of view, from a society point of view, it seems to me we could easily wind up spending more money that even if the goal of this is to contain money, we could wind up spending more money or putting more money in the wrong place, which is in the pockets of investors rather than delivering medical care, because this is not designed from everything I hear, to more efficiently deliver care or more cost efficiently deliver care. This is designed to more cheaply deliver care on a month per month, year by year basis. I can save money on treating you this year by making you so much sicker 10 years from now that it costs 5 times. This whole thing just doesn't make sense to me. It seems like a way to skim money for the private sector off a public program.
I think you've nailed it, Richard. I think the government thinks about efficiency as less care and not as better care. And so, and they have no way of knowing, again, whether care is good or not good. We know from the Medicare Payment Advisory Commission, which is the commission that oversees the Medicare program, that every year since its inception, Medicare Advantage plans have cost the government per person more than traditional Medicare. So it has not been cost-effective, Medicare Advantage. And in terms of quality, even though those Medicare Advantage plans are legally required to turn over complete and accurate encounter data, meaning data about the enrollees' encounters with doctors and the care they've been getting, they have not done so. And as a result, the agency that oversees them has no way to assess the quality of care they're delivering and has said so year after year. So how are we now going to engage in an experiment when we already know that it's going to cost more and we're not going to be able to assess quality in a good way? And that's not an experiment. That's just a mistake from the get-go. It's building on information we already know that completely already tells us that it can't work.
This, Diane Archer, it seems to me that this process, which they call direct contracting, it sounds like it could completely transform Medicare from what we understand it to be today. It seems to me like such a huge public policy decision on behalf of Wall Street and investors, the privatization of the public side of Medicare, which, over the next 20 years is going to be trillions of dollars. Seems to me that it would end Medicare as we know it, that it would put insurance companies and investors in control of our care. And yet, there's been no public debate about it. The public doesn't know about it. Congress hasn't debated it, to my understanding. It's just being done. Does the administration, does CMS have the authority to make such a fundamental change to our healthcare system?
I don't think CMS has the authority to do what it's doing. If what it's doing, and it looks like this, is to allow as many Wall Street insurers and investors who want to control care for people in traditional Medicare do so. The administration has some authority from Congress to quote unquote experiment, but you don't experiment on an entire population. That is just handing over, as you say, trillions of dollars to Wall Street. And that's what it looks like it's doing. There's just no evidence behind what it's doing to suggest that it's going to deliver good care. In fact, all the evidence suggests that there are huge issues, that people aren't going to get the high value care that they might need. Nor is there evidence to suggest that it's a cost-effective way to deliver care. There are other experiments that could be done. I mean, there are experiments that could be done where the federal government creates ways to manage people's care or coordinate care directly with the providers, but without an intermediary. We already have the Medicare Advantage side that has the insurer intermediary. Why would you put that into the traditional Medicare side? We see it's not working well. So why would you do it? The only answer is that Wall Street wants it, that it's money for Wall Street. And the administration, the Trump administration, wanted to hand that business over to Wall Street. And the Biden administration seems to be fine with it as well, which is really the sad piece of all of this, that they're willing to go along with it, at least as of now. I think what we need to do is make it a political nightmare for them. And it should be a political nightmare because nobody in traditional Medicare, in fact, nobody in Medicare Advantage should want this on the traditional Medicare side. Because so long as traditional Medicare is strong, Medicare Advantage plans have to do a little better by people who they enroll. Right. They're not doing well, but they have to at least be a little bit more competitive with traditional Medicare. As soon as traditional Medicare is not working well, the Medicare Advantage plans have less competitive pressure. They're going to do even less for their members, most likely, because that's the way Wall Street works. That's the way business works, as you said from the get-go. They're in it to maximize profits for their shareholders. Yes, some of them really do care about your health, but we don't know which. So it is a crapshoot. I like to say to people that they are playing Russian roulette with their health when they join a health insurance plan that is run by an insurer, because we just don't know if that insurer is going to be there for them or is going to be trying as best as possible to avoid giving them the costly healthcare services they need if they have a stroke or a heart attack or cancer or some other serious condition.
The one thing we know for sure, Diane, is that insurance companies make money by denying care. There's been a 50-year debate about how much of that denial of care hurts people, how much it doesn't, going back to, the Rand study in the 1970s or whenever. But the fact is they make money by denying care. It seems to me that what we should be calling for, but I'll give you the last word, it seems to me that what we should be calling for is not this kind of privatization of Medicare. I think we should do the opposite and make traditional Medicare stronger by eliminating the need for supplemental insurance so that people don't have to pay those out-of-pocket costs, by making sure that people are protected fully within traditional Medicare. And then, the insurance companies don't have magic formulas or secret knowledge that the rest of us don't have. Then use everything we know about the effective management of medicine to make public medicine for the people, stronger and better and more effective. But I'll give you the last word.
Well, that's Medicare for all. And absolutely, that's what we need. And I just want to add that the insurers not only are in the business of denying care, they're also in the business of driving up costs. And that shouldn't be lost on people, because the more money healthcare costs, the more profits they can make. So they're not even in the business of delivering lower cost care. They don't negotiate in any effective way to bring down costs for people. They pay top dollar, and they're happy to do so because, again, they get their piece of the pie, and the bigger the pie, the bigger the piece. So what we want is a system like traditional Medicare, and as you say, Richard, better than traditional Medicare, with fewer out-of-pocket costs or no out-of-pocket costs, where people don't face the financial and administrative obstacles to care that insurers put them through. It's just not fair. Being sick is already enough of a stressor. Nobody should have to face these kinds of hurdles, and these cost hurdles can really just completely destroy people. They get sick at a younger age, and they're facing, debt for, the rest of their lives. It's just a travesty. It's such an injustice, and we need to right this wrong. And the best way to do it is by guaranteeing everybody an improved and expanded Medicare.
Well, I couldn't agree more. And as always, Diane Archer, always super informative, and I was going to say fun, as much fun as this horrible topic could be, talking with you. So again, my guest has been Diane Archer, president of, Just Care USA, right? And what's the website for that again?
Yeah, visit us at justcareusa.org, justcareusa.org, for all kinds of, as simple as possible, information about how to get the healthcare you need at the price you can afford, or at the lowest possible price.
And simple as possible is what we all need. So again, Diane Archer, thanks for all the great information, and thanks for coming on the program.
Thank you, Richard. Have a good day. Bye.
You too. We'll be right back after this. I'm Richard RJ Eskow, and this is The Zero Hour.